So the next topic, we are moving on to complicated cataract surgeries by Dr. Sarath by New Vision Eye Hospital at Manjeri.
Thank you, Dr. Sunita, for the opportunity. I'll be mentioning the name of few devices I use. I do not have any financial interest in any of these devices. We all would love to do cataract surgery in such a well dilated pupil with very good red glow. But often we get some of these cases with varying degree of dilatation, varying degree of difficulties. So we have to manage these cases also. So, in managing the complex cases, a thorough, good preoperative evaluation is very important. It is always ideal that you see the case yourself in the slit lamp. You see how much dilatation is there, what is the maximum dilatation. You see what the grade of the cataract. Look for any sonar dehiscence, and there should be a proper surgical planning. Your theater, you should have all the devices like iris retractors, BHEX rings, capsular tension rings or segments, high viscoelastics, and your theater staff should be ready with the vitrectomy. And there should be always a backup lens, either a iris claw or a multi-piece IOL. Ideally, both should be available. Iris claw lens and a multi-piece IOL should be available in the theater. Phacoemulsification is possible in such a reasonably sized pupil. You can use high viscous viscoelastic to dilate the pupil whatever you can. Your rhexis should be little larger than the pupil size, and your hydrodissection should be in a right plane. And phacoemulsification, you be careful, you stay in the center of the eye, avoid any unnecessary movement, avoid any damage to the ocular tissues. And IOL placing also, IOL should be placed within the bag. But this technique may not be reproducible in all the cases. You can have complication. Sometimes your axis can become too small. Your hydrodissection can go in a wrong plane. Fluid can get misdirected into the posterior chamber, causing an intraoperative stony hard eye. And phacoemulsification, you are not clearly seeing the movement of the tip of the instruments inside. It can cause complications, like you can damage the iris tissue, you can cause PC tear. So, idea is, while doing the phaco, you should clearly see the movement of the tip of the instruments inside the eye. So, you should have sufficient dilatation. There are various techniques. You can use pharmacological agents like phenocaine. You can stretch the pupil mechanically. And there are pupil expanding devices like iris retractors, BHEX ring, Malusian ring, etc. This is a short video showing the use of iris retractors. After making 4 stab incisions at the limbus at opposite clock hours, you introduce the hook, keeping the hook parallel to the iris. Once you reach the pupillary margin, you can rotate, engage the pupillary margin and stretch it. Like that, 4 hooks are placed at opposite clock hours. Insert the hook. Once you reach the pupillary margin, you can rotate it, engage the pupillary margin and stretch it. Here, making the incision is important. Your incision should be at the limbus or little at the posterior side, posterior limbus. If the incision is anteriorly placed, it will cause tenting of the iris. So, incision ideally it should be at the limbus or little posterior limbus. These hooks which I am using are Alcon hooks. They are very long, thin and very flexible. It's very easy to use. So, once the 4 hooks are placed, you will have a well square shaped pupil. You can safely perform the surgery. You can clearly see the movement of the tip of the instrument. You can safely perform the surgery. After placing the IOL, you can remove the hook one by one. After placing the IOL, you can remove the hooks. The other most widely used pupil expanding devices are BHEX ring. These are 6 flanges. They have 6 flanges and 6 notches. Alternate flanges have holes and alternate flanges are plain. The flanges with holes will be tucked beneath the iris and plain flanges will be lying above the iris. Once it is placed, you will have a hexagonally shaped pupil. Here is a short video. These are very thin and flexible. Easily it can be slided through a 2.2 millimeter incision. There's a specially designed BX forceps is there. You hold the flange with the hole, you take it beneath the iris, tuck it beneath the iris. Simultaneously, the notch on either side will engage the pupil. It's important to fix the eye with the second instrument. You hold it at the center hole, take it beneath the iris. You can see simultaneously notches will engage the pupil. Repeat the same procedure on opposite side. You will get a nice hexagonal shaped pupil that is sufficient for such a hard cataract like this, more than enough. So removal also is very easy. You hold the flange above the iris, you pull it towards the center. That will disengage the this from the iris margin. Easily you can pull it out through the main incision. So removal is very easy. If you want more dilatation, B octa rings are available. They have 8 flanges and 8 notches. But most of the time, B hex ring is sufficient for most of the cases. The other challenging case are these hard leathery brown cataracts. Here, phaco will be difficult because this posterior plate will be very thick and leathery. It is very difficult to completely separate the nucleus into small fragments. Chopping such hard cataracts can cause stress over the zonules. It can cause zonular dialysis, and phacoemulsification, you will be using a lot of phaco energy. It can cause corneal endothelial problems. So idea is you create a very deep and wide trench at the center of the nucleus. So make the posterior plate very thin so that it will easily crack and you will get a very good hold of the nucleus. For chopping such hard cataract, you should have a very good hold of the nucleus. For that, 2 things are needed. You should have a very high vacuum and your tip should be buried deeply inside the nucleus. Then only you will get a good chop for such hard leathery cataracts. Here you can see the surgeon is attempting to chop, but nucleus is slipping. You can see the nucleus is slipping. It's not getting chopped, but it is getting slipped. This is because the hold is not good. So such case, you should stop there. You should either increase the vacuum or the tip should be buried deeply inside. Then you will get a good chop. Here's a video. The rexus should be a little larger in such hard cataract. You make a very deep and wide trench in the center of the eye so that posterior plate is very thin. You take time for this step. You make it very wide and deep. Posterior plate is very thin. Then you start to chop. Your lateral separation should be done in multiple attempts. In each attempt, you introduce the chopper, you do some separation, then you place the chopper further down and separate, then again further down and separate. Like that, you should progressively go down and separate. Instead of separating in one attempt, you should do it in multiple small attempts. If you do like that, stress over the zonules will be less. You can divide the nucleus into 6 or 8 small pieces, then your emulsification will be less. Your quadrant removal, you can use high viscous viscoelastic to protect the corneal endothelium. Once the fragments are divided into small pieces, completely separated, you will have very good followability. Your quadrant removal will become much faster and easier. So that's it. In a proper surgical planning and adapting appropriate technique for each case, we can significantly enhance the visual outcome in such complicated cases. Thank you.